Hi, this is Mary Kay Clunies Ross in the Chronic Disease Coalition. We've got a spoonful for you today. We are focused on learning a little bit more about prior authorization. This is something that's sometimes kind of a technical area, but people who are managing chronic disease have to face it and deal with it all the time. And no one knows that better than the providers. And so we've got Dr. Dave here to speak to prior authorization and frankly, to focus on what this means for patients and the patient experience. And so I'd like to just hand it over to him to introduce himself and his experience in this area. Dr. Dave.
Hi there, my name is Amish Dave. I'm a rheumatologist in Seattle and Bainbridge Island, practicing at Virginia Mason Medical Center, and happy to be here today to talk about prior authorization.
Great. Thank you so much. Listen, we'll just start with the basics. How do you explain to patients what prior authorization means when you're guiding your folks through that?
Yeah, so what I tell them is that prior authorization essentially is a process that's been set up by insurance companies to look at the medication that has been prescribed by a clinician
Mhm.
and to determine whether, quote, it's appropriate for them or not. I usually tell them that prior authorization is not something that's been determined by the clinician, by the providing provider at all, and that it essentially will mean that there's going to be some paperwork to be done by the patients, by their insurance company, and by the clinician who's prescribed a new medication. So, for example, if someone's been prescribed, say, etanercept for, say, rheumatoid arthritis, that usually means that that medicine is written as a script by the prescriber, by, say, myself, to the patient's pharmacy or to a pharmacy benefit manager that's contracted with a patient's insurance. And then afterwards, there's a series of questions or forms in the form of what's called a prior authorization that will come back to the clinician. And that'll involve questions about a patient's diagnosis, what medications they might have tried in the past to treat their, say, rheumatoid arthritis or their clinical condition. And then we fill out some paperwork, it goes back to insurance. They might have further questions for us about a patient's diagnosis. And then through the process, either that medication will be approved or denied in the prior authorization pathway. And then after it, say if it's approved, great, a patient gets their medication. If it's denied, it means that we might need to appeal the denial. And then that goes through a further process.
That seems like it would be really time consuming and create a
Yeah.
long delay between when you, as the doctor, tell them what they need and when they can actually get started.
Absolutely. It's a process that is frustrating. It makes my hair fall out every day. It requires a lot of staff time. And I often say that this is not something that any clinician has ever created. It's really created by the insurance system and their contracted pharmacy benefit managers to quote, save money for, say, the insurance plans. Often it actually doesn't do that. Often it just, the process of prior authorization can just raise the cost of healthcare in general for patients as well as for their companies that they might work for, especially when we're talking about employer-based insurance plans. But it is something that is often required for expensive medicines and might often be required even for relatively inexpensive medicines that have been on the market for a long time as well.
I've heard that it's happening more often. Does that seem like that you're seeing that too?
Definitely in our field of rheumatology, it definitely seems like it's occurring more often. Part of it is that even for generic medicines like, say, methotrexate that have been on the market since the 1970s, we're now seeing a request for prior authorizations appear. And so it is a huge concern. There's a great book by Dr. Elizabeth Rosenthal. Um, uh, oh my gosh, let me pause. The name of her book, I just had it on the tip of my tongue. Um, Called An American Sickness, which kind of goes into this history of insurances, pharmacy benefit managers, and the rising costs of healthcare. And I often tell patients who are interested to either pick up a copy of the book or get a free copy, say on Libby, for example, if the town that they're living in, like say Seattle, where I live, is contracted via Libby with the Seattle Public Library, to read a little bit more about this.
Mhm. What can patients and doctors do if they're in the middle of managing this right now?
So I think the biggest things I say are have some patience, and then find out through your doctor's office, say your rheumatologist's office or another specialist who's managing a chronic medical condition, like say a neurologist or a gastroenterologist, find out who's actually working in the doctor's office to process the prior authorization for you. A
Mhm.
lot of patients think that their rheumatologist or their doctor is the one who's handling all the nitty gritty. And indeed, we're involved in some levels, but most often there's someone in the office who's managing the prior authorization, say a medical assistant or someone who is a pharmacist, a clinical pharmacist, say at a hospital system like our own hospital system, who's going to be your point of contact to navigate you through the process. And I say that's particularly important because um, oftentimes patients will send a lot of messages or spend a lot of time on a phone call or waiting on the phone line to say talk to their specialist to find out what's the issue. Often we're the last people to know, or we might not know the most up-to-date information. It's usually that clinical pharmacist or the medical assistant who's managing all of the emails and the phone trees and the faxes with the patient's insurance, who knows where they are in the insurance, in the prioritization process for their insurance.
Mhm. And so if I'm the patient, I can maybe be helping on my side push my insurance company, who's the payer, and then working with the staff on the physician side to help do that too. So maybe by working from both angles, that moves the authorization faster. Is that what the goal is?
We hope so. Yeah. So there's some prioritizations are going to be more sticky than others or more difficult or time consuming.
Mhm.
So the ones that tend to move smoothest are when it's a common medication that the specialist understands is for a common medication that's been around for a long time for a condition that's relatively common. So, say for rheumatoid arthritis, if you're prescribing a etanercept and it's a patient who's either failed commonly used medications like methotrexate or leflunomide or hydroxychloroquine early on, usually your specialist can give you a sense of how difficult they think it's going to be for prior authorization to be approved. So typically etanercept or adalimumab might be approved very readily for that sort of a condition. And that's partly because your specialist will have some knowledge based on their experience working on a medical condition and their experience using medications, what's going to be approved sooner or later. So I usually know that in that patient, say with rheumatoid arthritis who's failed hydroxychloroquine and methotrexate, for whom I'm prescribing etanercept, I have a sense of based on my experience, that I can usually get an approval within 48 hours with our staff. That's going to be very fast. And so I usually try to give my patients some sort of a heads up, like, I don't think this is going to be that hard. I can be surprised by patients' insurance or their intransigence, but typically I say, that I expect the medication to be approved pretty quickly. There's other conditions that are much more rare where there might not be an FDA approval for a certain medication, where you're using a medication off label. And I usually tell patients, this is an off-label indication for this medicine, which means that it's going to be much more hairy and it's going to be a slower process. We'll need to document all the medications that have been tried first for this condition. But because this is not an FDA-approved medication, your insurance is going to deny it at first. I expect a denial. We're going to appeal that. And then if it continues to be denied despite my letters to your insurance documenting this condition, documenting references in the medical literature for why I think this medication is going to be a good one for you, then we might need to do a peer-to-peer appeal or request that I can get someone on the line. And that then the process gets even stickier because some insurance companies are great and I can get a peer-to-peer with someone who's a rheumatologist or someone who's at least an internal medicine doctor very quickly within a few days. Other insurance companies play games and they take a long time. I've had patients wait months to get for me to get a peer-to-peer, despite the fact that Washington state law might ask for the peer-to-peer to occur in a much more expedited manner within a week or so. insurance companies still play games. They'll pretend that they're calling um, the person in my office who's responsible for setting up these peer-to-peers. They'll say that they sent a fax, then they'll be out of office, then they won't return a call. And so these games can occur for a long time. And there are times in which I tell patients, you know, despite everything that our office is trying to do, your insurance company is still dragging its feet. They're playing games, and it's time to contact the office of either the Washington State Insurance Commissioner or the office of, say, an insurance commissioner in the state where their insurance is based. So I've had a patient, for example, recently who was denied their medication for a long time, for 2 months, despite having significant autoimmune lung disease that was really compromising her life. We ultimately found out that her insurance was based in the state of Massachusetts. She filed a complaint with the insurance commissioner in Massachusetts, and within a week, well, she found out almost immediately. Massachusetts opened up a case on her insurance company to investigate why she was being denied, and within a week, her medication was approved. That was after 3 months of delays and denials. So I've often found that if patients are willing to contact their insurance commission in the state where their insurance is based, that can often move things really quickly, especially if for some reason we're finding that insurance is dragging its feet. And so having a good insurance commissioner can be a blessing for many people and open up a lot faster the insurance process.
You said something that I want to go back to and clarify, because prior authorization is not just it's not just a temporary delay or an inconvenience. This is really, the longer it takes to get the medication, the worse the patient can get. So their outcome could ultimately be worse because of a long bureaucratic delay.
Absolutely. So in our field in rheumatology or say in gastroenterology for autoimmune bowel diseases, we're often prescribing medicines that are helping to control inflammation and prevent long-term damage to organ systems. So similar to neurology, worrying about the brain and the nervous system. So when people are denied or delayed their medications, it's leading to persistent inflammation. In my field in rheumatology, that could mean the joints and having permanent joint damage that doesn't reverse itself. It could mean other organ systems like the lungs or the gut that are being inflamed, or the
Mhm.
eyes with autoimmune eye disease that we might manage, and people having blindness or really worsened vision. So we get really frustrated by these delays in prior authorization. And I often tell patients, when they can get very frustrated. We get a lot of the frustration. We feel it a lot. And people are like, well, why aren't you doing everything possible? And I often tell people, our office is doing everything possible. We're often working at our fastest with many people, and we do this all the time. We're submitting paperwork as quickly as we get it because we really want to control people's inflammation. The delays are almost always on the insurance side, and
Mhm.
they have a financial interest in slowing down approval for medications because if you think about it, a medicine that's $40,000 per year. If they can delay that by a week or 2 weeks or 3 weeks or 4 weeks or 3 months, they're saving a lot of money over that period of time. And cumulatively over thousands and thousands of patients, they're making a ton of money. And the insurance companies are racking up huge profits, as are the pharmacy benefit managers that are providing these medications to patients. And so it's not the clinician, the physician's office that's causing the delays.
We've talked a little bit about the individual advocacy of patients, but that puts a huge burden on people who are already managing disease. What what are some of the policy changes that we can make in this area that level the playing field for all patients?
So I would say it's important to get involved with organizations that are advocating um, for changes at the state level and then nationally on this. So I know, for example, in our field in rheumatology, I often tell patients, if you have psoriasis, talk to the Psoriasis Foundation. If you have the Lupus Foundation for lupus, I know the Arthritis Foundation that I've been very involved with is really involved in legislation nationally on these topics. And then there might be other local groups that are really involved with this. In rheumatology, I'm a board member of the Coalition of State Rheumatology Organizations, the CSRO. And we have a really cool legislative tracker that's actually won awards that goes state by state and tells you what bills you can currently support or write to your legislators on. So you can actually look at what bills are going on at a state level, say in Washington, or Oregon, or Alaska are the states that I focus on the most. But take a look, whatever state you're at, see what bills are currently involved, and then you can write to your legislator um, in your state Senate and House seats, and see where they stand, and see if you can even set up a meeting with either them or a staffer to talk about the issues that are important to you.
That is great. Are there any other places where you want to direct patients to learn more on prior authorization and advocating with their insurance companies?
Yeah, so I would say, I think the Crohn's and Colitis Foundation does a great job for people with Crohn's and colitis. The American College of Rheumatology is doing some work on this as well. And I would say, I'm sure that almost for every chronic disease, there's a coalition or there's an organization that's really involved with this. So it kind of depends on you finding the people who you feel like you jive most with, who you feel are most responsive. I'll be honest, some states are a little bit better at this than others. I think Washington State is very blessed with having a lot of advocacy organizations with passionate people who are really involved in advocacy. And so other states might be a little bit less fortunate. So I think that's where it's beneficial then to work with organizations that are more focused on chronic disease as a coalition, and reach out to them and see if they can help connect you or network with you with people who are really focused on your disease process, if that's of interest to you. I also think it's just important for people to get to know their legislators, because for chronic disease, often legislators don't understand the barriers that you're facing. And I often say, like, save your fire for the people who should be hearing about this, because, sometimes it just takes a few people banding together and going to talk with their legislator for that legislator to really understand the stress that their constituents are facing from these issues. Because the next time something might come up, they might open up their ears a little bit more and their hearts a little bit more, and be willing to tackle these issues. These are long-term issues that we're dealing with prior authorization, and so it's important for people to build up relationships with their legislators and getting to know them over the long term too.
Yep. Could not agree more. And it's great to hear how the providers and the patients are partners, obviously in fighting the disease, but also in making for better legislation.
Yep.
Yeah, great partnerships there. Is there anything else that you want to tell people about your work or policy solutions that are helping improve the prior authorization process or anything like that?
I would say this, please check out the legislative tracker for Coalition of State Rheumatology Organizations, because a lot of that tracker is useful not just for rheumatology, but for prior authorization and issues that are occurring across different disciplines with chronic diseases. And then I would also say, like, get to know if you are facing really big problems for your insurance on getting a prior authorization expedited or approved. It is so helpful to know where your insurance is based and to contact the insurance commissioner of that state. And I've had a number of patients who thought that, say, since I live in Seattle and I practice in Seattle, their insurance is based in Seattle. And then when they learn it's a totally different state with totally different rules, just helpful for you to know that. And a lot of people don't take that time to know. They might contact, say, the Washington State Insurance Commissioner, and that person might not have any jurisdiction over their insurance because their insurance is totally based in a different state. So I'd say take the time to understand where your insurance is based, what are the laws in that state. Often, it takes just you can look at something like the CSR legislative tracker to see what's passed in a state like California or Maryland or Illinois or whatever state you're based in. But there's reform occurring in every single state. So just helpful for you to know where your insurance is based.
That is great. Thank you so much for this time. I really appreciate it, and have a wonderful week.